And let me say, okay, perfect. So I was saying it's a great pleasure for me to be here and talking about this progression of studies related to the developing the socio-cognitive behavioral therapy for suicidal behaviors for Latinx youth. It's an approach, and it's based in CBT, and you will be hearing how it came to life, and it's a culturally centered and LGBTQ plus affirmative approach. I have no conflict of interest, but I have to say that I have been locally funded by different funding mechanism in NIMH and the American Foundation for Suicide Prevention. And the objective that I hope to accomplish today is to explain the trajectory of developing a culturally centered affirmative CBT protocol with Latinx youth with suicidal behaviors. And the reason why this is so important is because there are health service disparities and also clinical disparities within the Latinx youth. And I will use the term Latinx to refer to all genders. And I also sometimes may use Hispanic, but I respect any way that people prefer to name this group. And particularly, that's how I prefer to call Latinx youth. So there has been health disparities for a while in clinical outcomes and in the same way in terms of having culturally relevant evidence-based treatment that has been tested for Latinx youth. And that's how they started a long time ago. Specifically, we have that still in 2021, youth aged 12 to 17 with an MDD, major depressive disorder episode, received less treatment than white youth. And I'm talking about Hispanic Latinx youth, right? So they received significantly less treatment. And they're also underserved with regards to mental health care overall. And we know by a lot of research and also a lot of clinical work that families, Latinx families, face a lot of barriers in different areas to access services. And as well, we know that evidence-based treatment for suicidal thoughts and behavior are limited. Overall, there's more, like a decade or more than a decade ago, there was less. Has been increasing over time, but still, again, when we put into the equation that is culturally sensitive or center, or that we take into consideration some of those characteristics of a specific population, that we have less. And also, it is not that much that has been done to test. Let's say we have a big trial. There's not that much trials that have enough group of Latinx or other underrepresented groups to make statistics to say if it's actually good for this specific group as well as for the general group. So that's another limitation that we have in the field overall. And I will show this graphic that I love to show all the time about how suicide attempt has been going over years. Latinx here are the purple line. And as you can see over time, and this is the Youth Risk Behavior Survey that the CDC does every other year, and with high school students. So here we have the representation of some race and ethnic groups, not all of them. Let me clarify that. And then we have the purple line, which is the Latinx youth that for many years were at higher risk, or let's say they reported much more suicide attempt than other groups. And that went down on the 2017, 2019, which is, that was great. But what happened on January of 2020? COVID-19 came, and then we had a significant increase from 2019 to 2021, right? And then on the 2023, which is the last CDC survey, we see that rate of people reporting suicide attempt, specifically for Latinx, I'm talking at this time, again, the purple line, is staying the same. And so this is an overall of what's going on with the suicide attempts for Latinx specifically compared to some groups. If we go in deep, and I'm only showing here the last survey of 2023, if we take a look specifically by sexual orientation and gender identity, we can see there is a huge difference of suicide attempt in this group. So cisgender and heterosexual youth report a 6% of attempt. And this is overall all ethnic groups. I'm not dividing here for a specific group. Overall, a 6% report a suicide attempt versus a 20% of the youth that are LGBTQ plus, including trans youth, a 20% more compared to the other. And this, it is repeated in every ethnic group. So I think we can see it here as a whole, but we know that this happened in every ethnic cultural group. And then, so that's suicide attempt. If we go a little less, when I'm saying little less, like a less at-risk behavior, but that is also a suicide risk factor, we can see feeling sad and hopeless, and take a look at this over time. And we also know that youth that are Latinx have reported higher frequency of feeling sad and hopeless over time for a long time. Right? So if you see the purple line, it has been significant all this year, the difference. The only year that it kind of level up is in this last survey in 2023, in which if you go, I don't know if you can actually see my arrow, but I am circling here, and the Black youth, white youth, and Latinx kind of are kind of in the similar range right now. And this is actually the first time that happened, because all of these other years, Latinx were higher. And we are also seeing an effect here of the COVID, in which 2021, if you can see, there was a huge increase from 2019 to 2021. And then in this 2022, it kind of go back. There's a decrease for Latinx youth who feel this way, but it's kind of going back to the normal. As it was in 2019. And this is my interpretation. I am sure there may be other papers there talking about the impact of COVID-19, but we all see that or saw that and still seeing the repercussion of that in kids at school and different areas of their lives. And again, if we see by sexual orientation and gender identity, just taking a look of the 2023 in terms of feeling sad, persistent feeling of sad and hopeless, we can see there's a huge, significant difference between those that are cisgender and heterosexual and those that are not. So this is just to show with numbers about the disparities that we know that exist, that it's showing the same surveys that the CDC overall nationally does for youth in this country. In terms of specifically trans youth in 2017, the CDC as well, in using a representative sample of urban district and state, did their own analysis, and this paper came out in which they show how trans youth were higher in so many different areas. And here are some, right? Not just attempts and feeling sad, but also risky sexual behavior, substance use, and being victims of violence. In Gisela and myself, Gisela Jimenez, which is my one of the co-investigators in my grants, we did a chapter about what is saying intersectionality around being Latinx and also being trans, for example. And we in our literature review, we saw that there are mixed findings regarding this, but we know for sure that if we compare trans youth versus cisgender youth in every group, there is higher risk factors. But when we combine ethnicity and being trans, if that's, if Latinx from because of being Latinx and trans are in higher risk than white and trans that are trans. So we found different study results. But we do know that intersectionality is important, that we have to take that into consideration, that we need to take a look of the different identities that youth has to know and understand the reality and what are the things that they are going through. And for that, this is the treatment approach and conceptual model that we use to understand the lives of the kids that we see, not only in the clinical work, but also in the research work, which is an ecological perspective. And in this ecological perspective, it's not just know that they are surrounded, by the family, the community, society, but also about the norms that are around it, about the prejudice and ideas that are being built in a society about a specific group, mostly when it's underrepresented or less privileged than others. So we can understand why certain things happen in our population, like internalized homophobia. Why does that exist? Why they're at higher risk? Well, there are a lot of reasons why that exists, is because we are in a society that has misconceptions about sexual orientation and gender, and mostly during these times. So obviously there are a lot of stressors in the outside that every person that embrace these identities have to deal with when they are seen different, rejected, when they see that is, even at this point, even their existence is at risk. So this is the model we use. We also believe that there are distinct factors for the Latinx community. These are the ones that I speak the most, but there are many ways in which, even if there are a lot of diversity, because there's a lot of diversity in every ethnic cultural group, we believe, and I believe, there are some commonalities as well. And these are some of those commonalities. Familismo, which is the centrality of the family, is that connections that many times there's the idea that family needs to be put first than friends than other people outside of the family. Spirituality, right? Even though people are not sometimes identify with a particular religion, even in their phrase of Latinx people, si Dios quiere, if God's want to, right? There's a kind of an idea of God willingness in our life, and there's things that depend on their own God's will if it happened or not. So obviously there's a lot of diversity. There are people that does not believe in God. I'm not saying that every Latinx person believe in God, or that every Latinx person believe that family, it should be first. I'm talking about values that are there, that are passed to us by our grandparents, our ancestors in different ways, and our community, right? That we need to know that they're present. Also, machismo versus marianismo. Machismo is in all, in some way, which comes from patriarchy in this society, in the American society, in many societies, right? But there's some particular gender roles that for some reason are more kind of reinforced or strict within the Latinx community, and also in other cultures, but I'm talking about Latinx community, in which I'm part of, just in case it haven't been clear. I'm a Puerto Rican woman, Puerto Rican cisgender woman who is doing this work, and also here in US, I identify as well as Latina. So these gender roles, in some ways, or in many ways, are kind of passed to us as well. What a woman's supposed to do, what a man's supposed to do. And I know that this is general, but there's also nuance specifically for the Latinx community. And I have a lot of dichos, sayings, which I will not get into that because we will not finish if I go into that we have been getting since we were little. And then also the personalismo. And personalismo is valuing close connections. And this is so hard to explain because it's just something that you need to live in order to understand, and it's seen a lot in the clinical connection when you know someone for therapy, for example, in which many times, or in other instances, some families could be tell me what I need to do. I mean, not Latinx families, just tell me what I need to do, and I will do it, right? Just prescribe me, just tell me, just give me the advice. In terms of Latinx families, there is a lot that needs to be built upon trust. I need to trust you first. I need to know that you really care. I need to see that there's a more warm connection. And again, I could be talking about this forever, but I need to keep going. But those are some of the values. And obviously the language, even though there are other dialects that are around South America and other places from Native Americans from different places, but Spanish overall is one common language that is shared among Latin Americans. And unfortunately, in different levels, Latinx experience racism and discrimination depending on the context that is receiving them, or the society, the community. And they're also a process of acculturation and enculturation. And acculturation and enculturation means the way that when you come to a new country, a different country, for those immigrants, right, they have to get used to the new culture. You have to learn the language, the ways, how things are done in the American way, navigate the system. There's a lot of things that comes with coming from one country to another. And this is for first immigrants, first generation immigrants. They come the first time and they have to adjust. I'm a first immigrant. I came here 12 years ago. So I have to go through that situation of getting used to living in a very different place for me with different customs. Even though Puerto Rico is part of the US, but still it is for me, first generation is like moving here, and it's like getting used to so many things, because there are definitely very clear difference from my perspective. But they're also not just the first generation, second generations. When we have kids, you know, the person that's come have kids, there's other dynamics that happen here that sometimes caregivers lose the perspective that their kids are growing up in US while they were coming from their ideas of their own country. So sometimes there's some conflicts that happens there when they see the world in different ways because of where they were born and the message that they are getting. And then we have the caregivers versus the youth. This is in second generation families, I'm saying, right? Where sometimes there's this discrepancy about how the caregivers or the parents see the world, how the kids is seeing the world when they are listening from their parents at home, how things were in their country, and how they are being raised in this new country. And then we have third generation, which is a different story, but I will keep going. So all of the things I feel, and I have been saying this since more than 10 years ago, makes a particular mix about how to treat the youth at suicide risk, specifically for Latinx youth, that impact their development of their identity, right? And I was not the first one who said that either. Luis Sayas has a lot of work before me related to Latina specifically. He was working for Latina adolescents and the relationship with suicide. So to understand all of this, I will keep going, which is more conceptual. When I was back in Puerto Rico, I proposed a study to understand, to develop a protocol specifically for Latinx, and that was supported by the American Foundation for Suicide Prevention. And in this study, which included an open trial, two treatment protocols were combined. One that was good or has been shown to be good in treating Puerto Rican youth with depression. And then another one which was good in reducing, which was the pilot trial, suicide attempts in youth in US. So I had these two protocols, but the one in US, it was a pilot, and it was not meant to be for Latinx, just white youth overall. And then the other one was adapted for Latinx youth in Puerto Rico, but for depression, not suicidal behaviors. So I had these two potential protocols that could be combined and that could be added, other perspective that I felt, and also research, like base research, was telling me that needed to be incorporated. And that's how the first draft of the socio-cognitive behavioral treatment protocol came to life. And then an open trial was done. And through that open trial, the protocol became more refined. And also I had a group of experts that I was going to them, here's what I am seeing. So it was an iterative process of developing this protocol. And then this is a change model that was kind of the product, right? CBT, the normal CBT skills, cognitions, coping skills, family interactions, that at that point, some of the CBT were incorporating also family interactions, but the prior CBT, like years ago, had nothing about family interaction. That was kind of at the time, some protocols were incorporating that. And then I added the identity integration component, the communication, the emphasis on communication among family members, and this issue of supporting versus conflict from the caregiver's perspective to the youth identity, or where they were at in terms of who they were, not just of sexual orientation or gender identity, but overall. And then the idea is that if this improves, then we will get a reduction in suicidal behaviors and psychological distress. So the product of this was a protocol. And then I moved to US with a training grant, and I had the opportunity to do a pilot RCT, randomized clinical trial. But before doing this pilot, which was supported by the NIMH, as part of the research, I did interviews with clinicians in US and in Puerto Rico, but the only ones that have been published are the ones in US. 10 in-depth interviews with clinicians here that were treating Latinx youth. What were the challenges they were confronting? What were the issues with the family? So I did that, and finally, it was this study has been published just, I think, last week. So it came out of the oven. So everything was done. I mean, we got what we needed from this experience, and it was incorporated on the RCT that was done here. But qualitative work takes so much time, and finally was published, and it came out last week. So here it is, and is available. It's an online, an open journal that any of you can go and read. So when we did that, this study, what it pointed out was to understand actually that cultural gap, that acculturation gap between caregivers and youth, and also point out to how the family, represented mostly by caregivers, also were kind of, I mean, in case of kids with suicidality, how that disconnection and gap between them and the society had something to do with this, and how all those layers were interconnected, which is part of our model, like an ecological model, where we have to understand so many things to get to the suicidal crisis that they were explaining about their cases, right? So basically, there are things in the environment, the school, in the mental health system, traumatic events for the youth, and then their parents had their own trauma, and economic hardship and community violence, so many things that were clashing in the family, right? But the clash in the family, they were kind of responding to also the environment outside, and the disconnections that the family was having with the society, and then the disconnection that they had between them because they were in different places in terms of the acculturation and enculturation level, which enculturation is, I didn't say this before, I will say it now, and acculturation is the level that you embrace the culture that you're getting into, and enculturation is the level um, of keeping, how much you keep from your heritage culture, from your background. That's enculturation, and that could play in so many different ways. For example, you can, you know, you could have high enculturation and not necessarily acculturated, or being very acculturated and low in acculturation. So there's multiple combinations. But what we're seeing here is that what is important to understand sometimes in US with immigrant families, one of the important things to assess and understand is how is that acculturation gap? An enculturation gap between them, between caregivers in youth and the family with the outside world. Those are some of the important things to consider, even though we are not the only one. So from this study, the session raising children in different cultures came up. Like I developed this session as a result of those interviews. And we also have a paper from 2022 explaining that session and giving example with cases that you can also check out. This is also publicly available. And what we did with this session was trying to even, foster empathy and rapport with Latinx Hispanic caregiver while trying to understand their personal stories, with the objective of assessing caregivers' values, expectations regarding child rearing during the adolescent phase, kind of to understand them and also help them see how their child rearing, their own experience may be different from the experience of their kids. And then we make this distinction. We have some highlight. What do we do with immigrant caregivers and non-immigrants, right? So if they're immigrants, we can explore and discuss cultural differences between their country of origin and the US in this case. And if they're non-immigrant, we can still talk about differences in times, right? The time I was raised versus now that I am raising my own kids. And that conversation has been so far very healing, very productive. So these are the purpose. And also in this session and with this work of this qualitative study, we had the opportunity to also see that we were in the right direction in terms of working on communication, and also was a reassurance of the importance of having manuals in English and Spanish. So we have manuals for the caregivers, manuals for the youth. So if the youth preference is English, which usually that's what happened the most, we can give the manual to the teen in English, and then to the caregivers, we usually use the Spanish version. Even though we're having with time more kids that are coming, they are first generation as well. So we have kids that we see that they are Spanish speaking as well as the Spanish. So it is important to have materials in both languages and have clinicians as well that speak both languages when we are working with Latinx families from different generations. And then we did the pilot, and the pilot, you will see where it's published in the next slides, but the pilot was done, this was done in a home-based setting. I have to say it was outpatient, but it was home-based. And there's a huge difference with that, because in home-based, clinicians go 2 to 3 times to people's home, and they have more flexibility of what they can do. They receive calls and they can intensify actually the direct contact as needed, because these are kids that are at a really high risk. So we found that it was adequate, that we could do it, that we could do this protocol in a regular clinic, which is home-based. And then the preliminary efficacy results were pointing to the right direction and great direction. We have median effects for depressive symptom, internalizing symptoms at 12 months in favor of the socio-cognitive behavioral therapy protocol compared to the treatment as usual, with the kind of the same standard, like home-based, the same type of clinician, master level clinicians in the community, and then a large effect for suicide attempt in favor again of the socio-cognitive. So this is what happened, how the line looked like in terms of depressive symptoms, right? There was no difference at 3 and 6 months, but at 12 months, the people that were on the treatment as usual went back up, those symptoms, but the persons in the socio-cognitive, they stay going down. So that's how the line looked like. And then the suicide attempts, these are the percentage. For 6 to 12, there was no attempt on the socio-cognitive. And then in the treatment as usual, there was a 36% from 6 to 12. And this is where you can find the paper. And it's actually right now is also available publicly. Anyone can read it. So this was good information to submit another grant. And then this one was supported by the NIMHD, and it was a full RCT. It was a hybrid RCT because we were trying to see efficacy, but also effectiveness, because this, again, is done, we don't choose the patient. It was not like going at advertising. It was kids that were in the inpatient unit, partial programs, and it was kind of the natural referral to home-based services. So we wanted to recruit 150, and the study began the same month that COVID-19 was all over the news. So all the protocols had to change, and that impact our study. We had to go to the IRB and put everything in for telehealth, and a lot of changes, and everything was kind of pushed back. It was a really hard time, as you may know, even for people wanting to engage in a study, because they had so much on their hands. But still, we were able to recruit 114 families, and with a recent suicidal crisis. And again, most people were coming from home, in-home and partial programs. And we followed them at 3, 6, and 12 months. And this has not been published. We are close to submit an article, and I hope everyone look for it out there when it's published. But this is the demographic. Just very briefly, I just want to say, I mean, most of the caregivers were born outside of US, and most teens were 60% were born in US of the teens, and most caregivers outside, which that means we have second generation families with it's kind of the combination that hypothetically I thought that were more kind of that clash of this gap, acculturation gap could exist more in this second generation because of they were born outside, the kids were born here. And then these were teens. Okay, wait, so I think I got twice the same. Yes, I'm sorry, let me move on. So again, second generation was the most, and kind of 1/4 in each first generation, so both coming from another country. And then third generation, we also have like 1/4 where they were both caregivers and youth born here in US. And in terms of language preference, which is kind of a proxy of enculturation, how much they keep of their culture, we have that teens, 60%, 64% prefer English, and caregivers in a 56% prefer Spanish, 1/4 both. But the reality is that in sessions, even though the caregivers say that they prefer Spanish or kind of this both, they end up speaking in Spanish in the sessions because they're talking about emotions. So at the end, it was more than what they were saying here in Spanish. I think I have it again. I don't know why this happened, but the socioeconomic status was also a concern. In terms of gender, 24% were trans, if trans male, trans female, gender fluid, non-binary, or were questioning, which is a significant percent, which reflect the reality of what's going on. Of course, they are higher risk, have more suicidal attempts because of all the issues that they live. Families usually have a really, really hard time, and Latinx, I think sometimes even more, in some families more than others, some not, but it's a difficult topic. And we have a 24, and then in terms of sexual orientation, we have 59% who identify as non-heterosexual. So all this here, all this diversity, 59%, which again is a reflect of the surveys, of the reality. And mostly had a mood disorder, 87, 88%. Second most prevalent diagnosis was anxiety-related disorders. Third was PTSD. We had a lot of kids with trauma. And even if it was not reflected on PTSD, still they have trauma, maybe just didn't qualify for a PTSD, but they had a traumatic experience still. So this is how our sample looked like. In the study that when it gets published, you will see that we also did exploratory analysis, taking into account gender and sexual orientation. So we split the sample because we have enough, even more. We have more, we call it like LGBTQ kids. We have more than the ones that are not. So we were able to do a nice analysis doing that as an additional analysis, which I will not talk about the result because I want them to be published and I want you to read it, and I don't want any publisher not to take my paper because I already said what the results were or something like that. So the treatment approach that we follow, as I explained, I already explained you the ecological model, what is our model of change, but there's also in the clinical sense some statements or things that we believe that are represented in this, in some statement that we do about different things. One of them in culture and society, and we have a lot, I will just present a few. In terms of culture and society, we explain that in Latinx, Hispanic culture, the family is very important. Culture usually establish beliefs or social norms, and our beliefs about what is right or wrong initially come from our family. And we also said some cultural practices do not support the well-being of each person in the family. So we will discuss those issues that do not allow basically each person to get to their fullest potential. So these are some of our statements. And I think we twist the language a little bit for the last one that is more relatable, but this is the same idea. The suicidal crisis, in other words, or in simple words, here we're just saying that it's a combination of problems, just not one thing, just not your diagnosis, it's not an individualistic perspective, it's an ecological perspective. And that there are also opportunities for change. Crises are opportunities for change. So those are one of our main slogans that we use throughout therapy. We work with the perspective of developmental perspective, in which, you know, adolescence is a phase and they are discovering themselves, and we believe that caregivers and youth have done the best they could. Obviously, we know there's a lot of range of different families, but we will start believing this until you prove the contrary, right? We believe that every family has done the best they could. And then we need to foster and promote mutual respect, which is something so important for the Latinx families, the respect, el respeto. And then in terms of sexual and gender identity, these are our statement. LGBTQ plus expressions are natural variations of humanity. Latinx families can learn to support their children even if they do not agree with their sexual orientation or gender identity. So we are not looking necessarily for them to we don't care if they believe it's wrong or not wrong, or how they want to see it. We just want them to learn to support their kids, to accept them as they are, to make peace with the idea that they have their own path and they are choosing for themselves, and this is who they are, and just learn to love them and accept them. So this is one of our, well, our two main statements for this. And we have a treatment protocol in which we have one first phase, which is the stabilization phase, or the crisis model is kind of to stabilize, and it is very focused on identity, and is an affirmative approach supporting identity development and exploration. And then obviously stabilizations. Once they finish and complete that phase, the youth, the teen, is the one who decide the next step. So that empowers them, give them choice, and help them adhere to treatment. So there are other options after the identity that they can choose from. These are models, and each model have different sessions. It's like 4 sessions, 5 sessions. In this one here, the ones that have plenty of colors, those are to choose from. The first one is for everyone, and it's 11 sessions, 5 for the caregivers, 5 for the youth, and 1 is a family session for everyone. And thanks to the research, now I have a program that I direct here in Bradley Hasbro Outpatient, which is called Mi Gente program. And we are seeing kids from 12 to 21. We focus on LGBTQ youth, but it's not exclusively for them. And we see mood disorders, trauma, and suicidality. But right now we have another grant with the American Foundation for Suicide Prevention. And what we are doing now is that we want to translate that home-based model to outpatient and see how much we can do in a regular outpatient setting. And we are also adding a community health worker to the team. So the question that we have here is, okay, this treatment was developed and we know it's evidence-based for Latinx youth. Is the best that we have for Latinx youth. There has not been any other study exclusively for Latinx youth for suicidal behaviors in a randomized clinical trial. So this is the best we have so far. What else do we need to add to make this work in a clinical outpatient setting? So we're adding the community health worker because no, there's so many barriers for the Latinx family. So we're comparing just treatment only versus treatment plus a community health worker. So that's one of the grants that we have right now. It's a big grant. It's the focus grant for the American Foundation, similar to an R01. And then we have an R34 with Mexico. This is kind of the summary of the trajectory of this treatment development. And here the focus grant is a step 5, but I also have a grant with Mexico in which this protocol will be conducted in Mexico City. And then right now I am in the process with my collaborator, Dr. Jimenez. We are training clinicians there, so we will go to an open trial and then a randomized clinical trial, a pilot one. So as is in research, we sometimes just go back, right? So we're going back. We are seeing if there's any cultural adaptation that needs to be done for Mexican youth, I'm sorry. And then we will see, adjustment in terms of cultural context, and then open trial, and then pilot. And then we will go from there and see how things work for them. So this is where we are at right now. And in conclusion, disparities in clinical outcomes exist. There are health disparities exist, and Latinx youth are a distinct cultural group who will benefit, and we have seen that it benefits from culturally adapted treatment or developed specifically for them. And the socio-cognitive behavioral therapy for suicidal behavior takes into account identity, family, and context. And we want to keep doing that. And we think this is very important in any type of treatment development. And as I said before, this protocol is the first psychosocial treatment with positive evidence of reducing internalizing symptoms and suicide attempt in an RCT with Latinx youth specifically. Conclusions, more culturally relevant treatments are needed, not just for Latinx, but a lot of other groups. Usually RCTs are done with everyone, and it is people researcher does not take a look on specific ethnic cultural group. And it is important to, even if you don't have the chance to make statistical analysis, but at least you can do qualitative, you can search more, you can have a look and see what's going on with this particular group, and not just put them all together without considering their particular needs and characteristics. So that's why I believe that treatment response needs to be looked at from the perspective of race, ethnicity, sexual orientation, and gender, for sure. And that's what we have. And also, obviously, I feel that Spanish, because of many reasons, should be used as a prevention strategy in the community level, state level. That will be great. So kids could retain the language of their parents, of their caregivers, of their family. That will help have a common language, strengthening connections between them. Usually caregivers or parents, it's harder for them to learn a new language if they just came to US, but kids could retain their language, and that will help them. So that's just one thing. A lot of people have supported this work. It's not just me, even though I have been leading this work. I have a lot of mentors, co-investigators, research assistant, collaborators, wonderful people that has been on this journey, and also the families and youth that we have seen. And I think any questions will be welcome. And also ResearchGate, I can be found on my papers and work in ResearchGate by my full name. So I think we have 10 minutes for questions.